please invite the panel to come up. Nicola Bedlington, Director General European Patients Forum from Brussels. Anders Blanck, Director General LIF, the research-based pharmaceutical industry. Barbro Westerholm, Member of Swedish Parliament, Liberal Party, former Director General of the National Board of Health and Welfare, very long the title here. Peter Odmark, Chief Analyst, Ministry of Health Department of Social Security. And Göran Lantz, Adjunct Professor Emeritus from Ersta Sköndal University College in Uppsala University, former Director of Ersta Sköndal. Nice crowd, and yes, thank you, Madeleine, for serving. You are all supposed to give great, well-analyzed reflections upon what the reports you just heard. That's a great task. If we start with you, Göran Lantz, what did you learn, what did you hear, what did you appreciate, what did surprise you in what you just heard about the reports?
The overall impression is that the interaction, cooperation between firms and industries, organizations and scientists is very fruitful, very valuable.
What would you think is the main obstacle there? What do we need to overcome? What's in our mindsets and what's in the structures that we need to rearrange?
Yes, as I'm here as an ethicist, I appreciated very interesting presentations about health, economy, demography, and such things. And I think they fit very well into what we call a utilitarian and efficiency ethics, which is rather dominant still and has great value, mainly because we must have that knowledge in order to make good democratic decisions. But at the same time, I must say that there are really alternatives. And I then think of a more personal-based ethics. If I should mention some names, let's say Emanuel Levinas and Knud Eiler Lögstrup, and of course, that's quite another approach, but I think it fits very well into the ordinary medical ethics, the clinical ethics, so to speak. I don't want my doctor to make a cost efficiency calculus over how to treat me. I want to speak to the doctor, meet her or him, and have a personal connection. And that's another ethical approach. And very well in that theme fits the thoughts about person-centered care, which we heard about this morning. The patient or everybody is not just this body with its physical and medical characteristics. Basically, we are a story. I am a story. Everybody here is a story, a huge story, including many, many life years, experiences, and so on. And that's our identity in a more basic sense than just the body, so to speak.
Thank you very much. Barbro, you've already said one important reflection. What else would you like to bring up?
It is the importance of involving the user, the patient, the older person, when developing various treatments, technical support, and so on. Because we who are healthy, we may have one view, what is ethical, what is useful. But the user, the person who is the target person for the technical development and so on, may see it quite differently. And we who are politicians, healthy workaholics, may think that a camera in the bedroom, oh no, no, no. While 92-year-old Olof, or so, as I said yesterday, might think it's great, because then I'm not going to be disturbed by her health personnel and so on. And this comes true also for robots. And I just mentioned that the Medical Ethics Committee in government now has taken up the discussion on robots. But hopefully we'll towards the end of the year come up with something what to think about, because many say, oh, robots. And the first thing we decided, we should try to get rid of the word robot, because that causes thinking which is not pleasant. But technical equipment to help you to live an independent life, that if we can find a short word for that, would be a good thing.
Thank you for now. Peter Odmark.
Yes, I actually take the camera in the bedroom that Barbro was talking about. I met a person from a Swedish municipality where they had experimented with this, and the aim was actually to increase the integrity of the old people, instead of, as you said, having people coming, knocking at the door and checking on them. And this was very welcome. A lot of people actually thought this was the better solution. It also happened to be a cost-saving initiative, but then some well-meaning person wrote a very glad article about, oh, this will, if we were to use this in all Swedish municipalities, we would save this amount of money. And suddenly, what was perceived as something that strengthened your integrity, was positive for you, was perceived as an evil cost-saving thing that actually was destructive, and they got a huge backlash against that program. And that leads me to one point of reflection that I made, I think, these days and maybe earlier too. I think what we have learned is there are huge possibilities to improve the life for many, many people. And there are a lot of exciting things. Not only Google is exciting, a lot of other stuff is exciting too. At the same time, I think these discussions, not so much maybe today, but otherwise, not at least in the policy-intensive corridors where I spend my time, there's kind of this doomsday thought about looming financial gloom, and the only thing we have to focus on is cost effectiveness, and we will never be able to afford the elderly, and so on and so on. And I think it might be a good idea to embrace the fact that, yes, this will cost more money. I mean, we don't know exactly. My predecessor showed these simulations and 70 and 80% and so on. We don't know. It's 20, 30, 40 years. But it's quite reasonable to say, yeah, a few percent of GDP perhaps. That's a whole lot of money. But over a few decades, it's nothing insurmountable. It's perfectly possible. And considering the amount of increased human autonomy, dignity, and so on we can get for that, if we have the mindset that, yes, we have great opportunities, it will cost a lot of money, and that's worth spending, then we might be able to look at things a bit different and embrace these new possibilities in another way.
Thank you. Nicola Bedlington.
Well, I don't think it's going to be a very polemic discussion, I'm afraid, because I'd just like to endorse the comments that all of us have made so far. I'm obviously coming at it from a patient's perspective. My organisation is an umbrella organisation, 64 umbrella organisations covering the whole spectrum of diseases, the whole of the European Union, 150 million patients with chronic diseases. And what I feel I've learned here, I feel has huge resonance in a European Union context. The European Union is doing a lot of work on active and healthy aging. There is a massive partnership going on right now, the European Innovation Partnership on Active and Healthy Aging, that is coordinated in Brussels, but there are massive numbers of activities, of policy initiatives, etc. We're coming up to a midterm review in that process, and the fundamental objective is by 2020, every single European citizen will have additional 2 years healthy life years, additional 2 years. That's the basic objective. We're coming up to the midterm review now, and I think all of the richness and learning from this conference, my dream would be that that is somehow fed in a fairly systematic way to this process, because I think the wealth of knowledge here, the researchers, the people who are active in the field at local level, and the policymakers could add a huge amount to that. Clearly, from my perspective, patients, older people are not the problem. We're actually part of the solution, and possibly and arguably our experiential knowledge and expertise is the most underused resource in the health and social system. So meaningful patient involvement is also a big message from my perspective. The other thing I think we need to reflect on is the fact that we've talked a lot about prevention, about primary prevention, about health promotion. In fact, it should be part of one continuum. Primary prevention, health promotion, and patient-centered chronic disease management, it all goes together. There's no contradiction, and it hurts me sometimes to think that there's some competition between prevention, primary prevention, and secondary and tertiary prevention. I think we need to look at that from a policy perspective, but also potentially from a research perspective as well.
Thank you. Anders Blanck.
So, thank you very much. It's sometimes problematic to be last in the line because you can always, maybe it's easy, you can also always agree with everyone. That's what we do in Swedish panels most of the time. and we will do it now once more. I think that's been an exciting day for me. Sorry to say I couldn't participate yesterday. I think I'd like to continue with what Petter was actually talking about. And I think I actually wrote a couple of words which was more or less the same thing as Petter did. I think we need to find a way to embrace the future. I mean, this is really a fantastic development we've seen over the last decades. It cannot really be a problem that we live longer lives. Technologies cannot be a problem. Medical success, medical progress cannot be a problem. It's all in our heads and in our different systems and models that we have, that Petter is alluding to, which I think is the problem. How can we turn the demographic challenge, which is always referred to from different politicians, all over Europe at least, and I think most of the world, like a problem? How can we turn that challenge into something which is a possibility for us? And how can we channel all these elderly people? I will soon be an elderly person myself. How can we turn this interest to take part in creating one's own health into something that we actually can make use of in providing better services and to change the models and system? Because we have a problem in the models and system, which Paula referred to. But the systems and the models, we think about systems, not about persons. So we need to, there's some radical changes have to make in order to move to this person-centered care that everyone wants in theory, but we have problems delivering in real life. So I think we all agree that we can actually make use of all this knowledge, and we have to make this into something positive. And there are a lot of good things going on around the world. I wrote this article yesterday that only in the US, US companies now have 400 drugs, medicines in the pipeline to improve the conditions for the elderly. Only for the elderly is 400 medicines. Is that a pro or a con? Is that good or bad? Well, today we say, well, it's rather a challenge, isn't it? How are we supposed to take care of those? And they will probably be very expensive. So we need to find ways of doing this. So if we all join hands and we try to bridge the different gaps that we were talking about between science, different science disciplines and theory and practice, and to patients and citizens, but also between theory and politicians, so we can do a lot of change during the past. But this is something, it's an extremely pleasant situation we have. We can really do something good about this.
Thank you so much. Göran, you wanted to...
I think the most sad thing I heard, the most tragic thing during this conference was the message that it's very difficult to engage young people in caring for older. I mean, the lack of staff. And I think that reflects two things. One is an underestimation of these professions, and the other thing is the underestimation of old people generally. That is to say, ageism, which is a big problem.
And Barbro, yes?
Well, someone said to follow on that low status being old, and of course then it's low status to work for the old. And we have to find remedies for that. I think we should show the value, the resource that older people represent. I've tried to get Parliament to decide on that in the national accounts should also be included the value of all the unpaid work that older people produce, being next of kin, caring for a husband, or watching grandchildren, or being members of a voluntary organization, Red Cross, and so on. And I would say that if all the older people who do voluntary work, unpaid work today, would go on strike, the society, well, we complain about strikes in trains, but the society would fall together. So somehow we have to show that people after retirement are still a resource, and they are a resource until the last breath they take, because they carry stories, they are valuable to at least next of kin.
Mm. So how much does this have to do with our expectations? Yeah. What we expect from older people? You're 65, you're out of order, more or less.
Yeah. I mean, this is age discrimination, as you say, and we have got the legislation now that it's illegal to discriminate because of chronological age. Last year, 262 reports were sent to our discrimination ombudsman. And the ombudsman hasn't done anything with these reports. They haven't resources to analyze these in depth. And here you find, out of the 262, 69 are reported because an older person has felt being discriminated in his or her contact with governmental agencies. And so government should start really educating their own staff how to meet older citizens. Then I think a final thing is that we who are older, we are responsible for being role models and showing ourselves also that we are individuals doing all sorts of things. Don't say when you ask someone, older people, what are you doing? I'm only a pensioner. You should kill that sentence. Say, I'm doing this, that, and I'm proud of it.
I must be rude enough to ask, as a role model as you are, how old are you, Barbro?
I will be 81 the same day as on your birthday.
Okay. Congratulations. Yeah, that's a great date. That's wonderful to know that you are probably more, of course you are, more experienced, more knowledgeable, wiser. You have all the experience of the pitfalls, of the successes. I mean, that is invaluable if we start looking at it. Wow, let's go to Barbro, because you will have it. I mean, it's all in our minds. Petter?
One of the somewhat disconcerting thoughts that has struck me during this conference is that there are some facets or tones of the conversation, I think, and I think this is a recurring theme when we talk about these issues, that are more paternalistic and kind of objectifying the people that we are somehow talking about. They are someone else, not even Barbro, but they are someone else. And the aim seems to be, I mean, even the name of the conference and the healthy aging, I think is a bit troublesome. I mean, the whole day yesterday was about prevention and so on. I mean, aging can't be prevented. Disease, if you don't die from an accident, can't be prevented. Death can't be prevented. Sometimes we have learned today by Professor Van Hout, it's even more expensive in the long run to prevent things, because it's cheaper if people die younger and of cheaper things and so on. But it's the focus, which has been mentioned many times too, should, in my objection, be nothing else than the focus is in public policy and so on, in any case, which is individual autonomy, and that's still, it's just a tool. Autonomy for me is just a tool to make sure that I have the opportunity to control my life in a way that gives me value. And that might be not having a personal coach terrorizing me about the red meat and stuff, because I'm perfectly glad not being 120. And I'm not sure what the purpose, if a society where everyone is 200, is that better than everyone is 100? I mean, inequities and so on, that's a problem if some turn 100 and some only 50. But there are a tendency, I think, sometimes to disregard the value and the central value of autonomy. And autonomous aging, to me, would be the perfect goal for a conference and maybe the next conference. And autonomy changes. We were discussing it with the person-centered care, that, of course, when your own resources are smaller and you are more reliant on support of others, then it's more of a challenge to also for policy and for caregivers and so on to preserve the autonomy. And the expression of the autonomy might be different. It might only be that I have the availability to choose when I will eat in a nursing home or when I will do stuff. And it's very small things, but that is still the things that are humanly important, to be able to control these aspects of what gives me meaning and value. And that's a cautionary word of not being too quick to prescribe what the perfect aging and the perfect life is.
I associate when I hear that to one problem, to use the word challenge anyway, with osteoporosis being a very large health problem in Sweden, where we have such little sunlight and when people break their legs and it's very costly. And I just happen to know that you work with the device technology that will enforce the skeleton, so we will prevent, which of course could be a way of ensuring autonomy. That was my association, how that could be something. Would you like to just say something about that, what kind of work that is?
Yes, I also will comment on I work with training.
Physical training.
Yeah, physical training, and I'm very happy to see the result of what you thought would give a good aging. We are introducing a new method of treating osteoporosis. It's an American product. It's introduced in the whole rest of the world now, and it's called biodensity. It has nothing to do with pharmaceutical treatment. In a study, we have gained in 1 year of treatment an average of 7.7% of growth in bone density, which is fantastic. You're welcome to visit our website.
And the website's name is?
It's THRAB, Training Health Rehab AB.se.
Okay. Thanks, because all those things that will enable that technology now has, but is not well known, of course. I don't know what you say from the patient's perspective. Do you think it seems as if there is a great gap between all these innovations that could really prevent a lot of problems and suffering, and the difficulties in reaching the patients? Is this something you encounter?
I mean, again, it boils down to meaningful patient involvement in these innovations, and also the blend. I mean, pharmaceutical innovation, technological innovation, systems innovation, social innovation. Too often that's all segregated, and that needs to come together with the patient input as well. And coming back, I mean, I totally agree, one size doesn't fit all, and living to 150, that is not necessarily the ideal. But I do think there's a lack of a coherent strategy around patient empowerment or people's empowerment, because we've talked a lot about information and quality information. Health literacy has been mentioned, and in a sense, we need to move forward on health literacy. Good quality information on its own doesn't really help any of us. We need to understand and have the skills to be able to navigate that information effectively and really be constructively critical about the health and social care that we get. And if there could be more thinking together about a coherent strategy, either here in Sweden or preferably from a European perspective, I think that would be fantastic.
We have one wonderful example here in our Swedish history, 120 years ago, when we were facing terrible problems with tuberculosis that was really threatening the entire population. We were smart at that time, before all this technology. I just love this example, because the focus, the vision from the leaders at the time was, we need to exterminate TBC, tuberculosis altogether. What do we do? Well, one part is information. That is to tell people not to spit on the floor, to open the windows even though it's cold, to clean the blankets, whatever. That's one part, but that won't do the work. We need to do the emotional, to open up emotionally, the hunger, to really get all this information. So they thought, who is a very good storyteller? Selma Lagerlöf. She is a Nobel laureate, excellent writer. We will ask her to write short stories where children die in a very sad manner from their parents, and where parents die from children. And these stories are to be told in open public areas, in the churches and Folkets Hus, of common ground, so that people will get so emotionally motivated so that they will ask for the information. How can we prevent this, with the factual information that we love in our engineer culture to present, and sometimes believe will do the work. And then the third part was early intervention. As soon as somebody started coughing and having problems, they had mobile units with horse and carriage that would come and do the operation. And with these three aspects, information, the storytelling that was reaching out to the audience, and the early intervention, we succeeded then to really reach the goal, whereas now all these bits and pieces are still around, but nobody has focused. I was thinking when you were talking about that, to really gather all the know-how, the insights, what is it that make people change on a lasting level, and to maintain this, what do we need to do? Yes, please.
Very interesting. I would like to come back to that. I think that's you're referring to something very interesting. We have so much knowledge, not least after listening to Nicola. I know we have much more knowledge when we enter this room, so I don't feel that very knowledgeable. But anyway, we have a lot of knowledge. But somehow we want it all. And I think what's happened during the last decades, we could have had this summit in Uppsala 10 years ago, because we were talking about the demographic challenges for so many years. We talked about healthy aging for so many years, because we know that we need to do something. We still see this improvement in life years, etc., so which is very good. But we have problems in prioritizing today. We talked a lot about priorities in our workshop, in our session. We talked about priorities, regulatory priorities, health economic priorities. But we want it all. At the same time, we want low costs, we want low taxes, we want freedom of choice, because we know that's really, really important, as Petter alluded to. We want equity. And sometimes choice is not the same as equity, is it? And in those you refer to, 120 years ago with Selma Lagerlöf, there was a very strong national government. People were not that knowledgeable. Today, people don't want to be patients anymore. They're not very patient. They want to be some sort of co-creator. It's not a very good word, but they want to be there to create their own lives. Maybe it's not even healthy. Maybe they want to smoke until they're 8 years old. They know about the health risks. They still do it because they like it. So in one way, we need to find ways of having this patient-centered care facilities, and we need to have choice. We need to listen to what people want in their lives. But how do you do that in these different models that we all come from in Europe, for example, where we have systems, models, where we try to build societies which should be equitable, they should give everyone equal access, they should be the same for all. And it mustn't cost any more money, because we can't afford that. So I think that's the real challenge. And if we can use some of this knowledge that represent the people in this room and the people that's left us to go to trains and flights across the world, I think that's immensely interesting to see, because we've known this for a long time, but somehow we need to be able to discuss the systems, the models, the reimbursement systems, the financing systems, the tax systems. So I think as long as we don't do that, we don't make any real priorities. So I think it's very interesting to look at the Selma Lagerlöf example, and how would that look today exactly. in that context.
I was thinking when you say that about how we want it all at the same time, when Richard and I were preparing this, you said in a way that as if it was self-evident, that you said as a parent you always tell your children that in order to achieve this you have to sacrifice that. If you want to have fun during school time, you will sacrifice your options in the future, or the other way around. If you want to have the high grades, you will have to sacrifice some of the and we are in a instant gratification, everything now culture, where we don't want to sacrifice the taxes in order to get that. And maybe this is an educational also part of it. Sorry, Barbro, you wanted to comment.
Well, I wanted to bring up this storytelling.
Yes.
And if we want to change the situation, the importance of the right senders. Of course, we have realized now that it might be better for people higher up in ages to move to a more comfortable, convenient apartment or house. But we all live with the view that we should live in our old apartment or house until we die. Not everybody wants to, and some dare not move. But if we get the stories of those who dared to move, and the freedom you might experience, or these people do experience freedom from all sorts of things that they never used, and not to have to worry about dust and things, and so on and so forth. I think we could change matters. But if we politicians or governmental people say, it will be good for you to move, people will stay. But if, but if the representatives from the organizations for senior people tell themselves what kind of freedom they got, well, we might change things. The other thing was when we sat there with our mentometer and physical activity came up top. If this audience had been filled by senior citizens from the organizations, I think social network would have come at the very top. And physical activity can create such a possibility. Yes. I'm thinking of the 90-plus people in Sickla municipality, Nacka municipality, south of Stockholm, Stockholm, who meet every Friday at a gym, and they do all these gym things, you know. It's been on the TV. And when you talk about this and they, well, it's fine to go to the gym, but it's the hour before and the hour after which is most valuable. They have something which they can gather around. Right. But it's the social network, these men and women 90 plus experience.
Perfect. Thank you, Petter.
I was thinking we have made priorities. I mean, take, for example, we have privatized a large part of what was home care 20 years ago. And instead we have tax subsidies that enable people to buy home care themselves. I mean, 20 or at least 30 years ago, if you looked at the population getting home care, it was much more healthy, and today it's concentrated with the biggest needs. And I think that sometimes, I was thinking about the social interaction. Sometimes we have a tendency to view public policy in this area as either or. I mean, it's nursing homes and home care, resource intensive and expensive, or it's stay at home and live in your house and we will step in when you need the nursing home or the home care. But there are examples where very small amount of public policy or public funding can make big difference. I was thinking about the example from New York yesterday about the toilets. I thought that was a fantastic initiative. I mean, instead of making it a big expensive public commitment, you use the public, the power as a tool. And social networking, I listened to the radio a few weeks ago about initiative in Skåne, south of Sweden, where they had these speed dating clubs for elderly people don't having a lot of friends. Most my friends have died and I'm alone. And okay, that was a public initiative, but extremely cheap, but still that small thing that made a big difference for a lot of people. And you have housing. I mean, Barbro was chair of the Äldreboende delegation, and suggested this safety housing or whatever you should call it in English, trygghetsboende. And I mean, it's a public initiative, but it's mainly private housing, and it's not something the state or the municipality give you. So I think what we might be missing from a public policy view is there are probably a lot of small initiatives with resource cheap, but that can make a big difference in this part of your life when you're not actually so sick and that you have had a nursing home and so on. And that I think we can find more ways to explore those opportunities without costing a lot of money.
Thank you. And as you said, animals or singing in choirs, there are many ways, very inexpensive ways, that can make all the difference in the world to how we create this. But the vision is necessary. Dear cutting-edge guests, any questions, to the panel, any associations? You just want to be fed right now. That's okay. You just don't want to feel that you feel missed out from the dialogue. Because this is, as we're saying, only the start of the dialogue. This is not the end. I feel like Churchill. No, this is really just the end of the beginning. So it is indeed a very important thing to gather all the best practices, of course, and as you say, the little things that can really make all the difference. If you have a request, what would you say then, Nicola, from the you said you wanted more discussions on maybe a European level. Yes. What would you, if you can make a request now, what you would like us to gather? What kind of people or questions?
I think that the crowd here has been a very good crowd in the sense that it's multi-stakeholder, that it brings together the science community, it brings together practitioners, policymakers. What would be fantastic is in the next round that it's more European, there's more of a European dimension, a European perspective, because that can only bring richness. And I think certainly richness for some of the other countries in the European Union that are grappling with exactly the same things, perhaps with different models, different health systems, different social systems, but this shared learning is enormously rich. And working where I do with patient organisations from countries as diverse as Bulgaria, Ireland, Denmark, I mean, it is incredibly diverse, and in a sense, we're talking here a little bit about the icing on a cake. And in many of these countries, in terms of access to healthcare, and particularly the way that older people are treated, it's a very, very different world. It's a very, very different world. So from a solidarity perspective, I think there's also a lot of things that could be contributed by making this summit a little bit larger, and also linking in perhaps more specifically to the policy environment that's happening in Brussels, because it is very exciting right now. We have a brand new European Parliament. We'll have a new European Commission by the end of this year. So the opportunities and possibilities to feed that and hopefully get something better for all European Union citizens, not only Swedes, would be great.
Wonderful. So the final row now would be how you as persons would like to picture yourself as an old person, and how you would like to design the world where the integration or whatever the existence. Just paint, Göran.
Yes, I'm already an old person, so I'm very
It's
content
easy to
with
imagine. Yeah. How would you want to live as an old person? What is important to you, and how would you like to see the dream society realized?
In principle, the same of the same kind, so to speak.
Yes.
I want to continue with my interests, with my activities, and so on. And yes.
Thank you. Barbro?
I think it's vital that you are somebody all your life and not turn to nobody when you retire. And that chronological age is a very bad way to describe people.
Thank you. Petter?
I suppose that there are, you never know, but educated guess or not educated, a guess would be that pretty much the same things will give me pleasure in life and meaning as they do today. And I just hope that I will find ways, appropriate and new ways to make it possible for me to behave like I want to do as long as possible. And after that, to have a safe, safe environment just where I go to die, without having people trying to wake me up too much, and hopefully that period will be quite short.
Thank you, Nicola.
I guess probably 3 Ps, not the public-private partnership, but I guess people, we've talked about people-centered care, but actually people around me as I become older. Participation, still the possibility to actually engage. And I think what is underestimated so often, there isn't enough policy focus on this, is palliative care. We've talked about the cost linked to patients, people becoming ill in the last few months, years of their lives, but actually palliative care from both a quality of life perspective and an economic perspective, in my view, deserves much more attention.
Thank you. Anders?
What you realize is when you're soon turning 50, which is a very frightening age. You have to remember that when you're 18, you thought people that were 30 were extremely old. I remember my dad; he was 33 on the day I was born. And when I grew up, he was old. He was terribly old. You know, he wore a hat and a stick. You know, he was extremely old. He was born in the early 30s. What we see now is the last decade of really old people who remember what it was in the old days. And I realized that my mind hasn't turned. I'm not one single day older in my mind than I was 18 when I'm almost turning 50. So you have to realize that I'll probably be the same in another 40 years. Like to do the same things. And as everyone says, what is really nice is that you be able to live the life you lead, to have the financial situation, which means that you can actually choose where you want to live. If you want to stay at home, live in your house, probably not. I would probably move downtown as soon as I can when the children move out. But I don't think that life would change that much, and I hope it won't. And I hope I will be able to choose whatever I want to do. So we have to remember that this aging thing is just something mental. So we really need to believe that, like Barbro said, you have to be someone all the time and not no one when you turn a specific age. So I think that's really important. So I would probably be more or less the same. Unfortunately, I would probably be more or less the same.
Thank you, dear panel. Thank you so much.